Hey, DNA. Kate Wilson here with another episode of All Access DNA. Today we are talking about bleeding disorders, what they are, how they impact periods, and what are signs of bleeding conditions, and why they are underdiagnosed. My guest is Kaylee Dollerschell, a genetic counselor who specializes in hematology. She talks about testing for bleeding disorders, treatment options, including gene therapy, and the impact of bleeding conditions on pregnancy and daily life. Let's get started. Hi, Kaylee. Welcome to the show.
Hi, Kate. Thanks for having me.
I am very excited to have you on because I saw you at a conference talking about bleeding disorders and individuals assigned female at birth. And I was really struck about some of the stats that were shared about heavy menstrual bleeding being the most common bleeding symptom and how it actually affects like 90% of us assigned female at birth with a bleeding disorder. I was also realizing how common some of the symptoms of bleeding disorders are. And I wondered if people actually know when to talk to their doctor or when people have questions about nosebleeds or easy bruising, because again, these are very non-specific types of things and they occur often for folks. So I'm just really excited that you could come on and share more about this topic because I learned a ton, even just from that, I think, hour-long talk. Even having been in the field for 20 years, I learned so many new things.
Well, you're not alone. I continue to learn so many new things, and I definitely did not know nearly as much about the bleeding disorder kind of community and everything that goes into it until I was part of this world. So I'm excited to share it, and there's a lot of resources out there that will be great follow-up to this that hopefully people can go to if they have questions.
Perfect. Yeah, we'll put a list too in the show notes. That way folks can click on that if they have additional questions or looking for more information. But I guess let's start at the beginning. What is a bleeding disorder and how does it affect the body?
Yeah, and a bleeding disorder, in order to kind of talk about it, and I'm not here to put us to sleep during a podcast with a bunch of heavy scientific things, but, when it comes to your body needing to form a blood clot, so anytime that you have any damage to a blood vessel in your body, whether it's the smallest blood vessel or the biggest blood vessel you have, there's this whole slew of things that end up happening in the body to help you form a blood clot to stop the bleeding. And at least for me, until I really delved into the world of bleeding disorders, I kind of always thought of your platelets as being kind of the main player there, and your platelets play a very big component in helping you form a blood clot. But there's actually this whole other world of kind of what we call the clotting cascade, or kind of these domino effects of things that happen in the blood to help you form a blood clot. And there's these clotting factors, just a fancy word for a protein, that kind of like a domino effect, one thing activates another, and then they all kind of get together, even with platelets, to form a blood clot. So a bleeding disorder really comes down to, and most of the time in our world, is somewhere in that domino chain, something didn't work as it's expected to, and you did not get to your blood clot as quickly as possible, and you ended up having too much bleeding. Now, today we'll talk a lot through familial or maybe hereditary bleeding disorders, but in general, there's also a lot of other reasons that people can have extra bleeding. There's things like vitamin K deficiency and liver disease and certain heart defects and things like that. But there's a lot of underlying genetic conditions that can also cause somebody to have a bleeding disorder. And ultimately, a bleeding disorder just makes it so that you're not forming a blood clot as quickly as you should, and you have extra bleeding. And really, the symptoms of that can be really pretty variable.
Mm-hmm. I think that's so important to note, is that some of the bleeding disorders, bleeding conditions that we talk about, like you said, some are genetic or caused by a gene change. Some are hereditary, being passed through generations. And then some have completely other different environmental types of things that people are being exposed to or not exposed to that might impact it.
Exactly. And so, as we go through, it's really important that if you think you may have a bleeding disorder, or somebody that might have one, is that they're going to explore a whole ton of different things before they may see genetic counseling or consider that there's some type of an underlying hereditary bleeding disorder. And it's kind of a journey to kind of work through those different diagnoses as you go through that.
Mm-hmm. Yeah, I know sometimes it can be like there's a laundry list and we're just trying to kind of cross off some things, which we're trying to get to the right answer, but sometimes it can be frustrating and challenging, especially when you're the patient and you're trying to figure out what's going on.
Absolutely.
Maybe you can tell us a little bit about some of the signs of a bleeding disorder. I know we talked about a few at the beginning, but maybe you can elaborate on those.
Definitely. And again, going back to my maybe naive brain before I worked in the world of bleeding disorders. I think I always thought of somebody that has a bleeding disorder, gets a paper cut and just never stops bleeding, or something super drastic like that, which we do have some individuals that have bleeding disorders that can have significant bleeding with injury and things like that. But a lot of the symptoms of a bleeding disorder can be really subtle all the way up to severe. And maybe some of the more subtle things you see are things like you mentioned, like easy bruising. That's really tough because a lot of people can bruise for a bunch of different reasons. But in our world, if you are, presenting with more than 5 or so bruises at a time, or you get some really gnarly bruises and can't remember where they came from, we start to kind of wonder what's maybe causing that. Other things like nosebleeds. Nosebleeds can be caused by a lot of things, dry weather, elevation. But when you're starting to get like more than 5 kind of spontaneous nosebleeds a year, or your nosebleeds are lasting longer than like 5 to 10 minutes, if you're needing to have your nose cauterized, again, the combination of things start to get a little bit suspicious. Gum bleeding. Again, one of those things that you can have gum bleeding because you don't floss or brush too often, or you could have different types of gum diseases. But when you're having it on a very regular basis, or bleeding with like extra bleeding with tooth extractions, dental work, again, something we start to look into. And then, in terms of our females assigned at birth, something that is often, like you mentioned, a symptom of a bleeding disorder tends to be heavy menstrual bleeding, and or maybe having hemorrhage or extra bleeding during or after their delivery with a child. Also, kind of for both females and males, you can have extra bleeding with certain surgeries, whether it's right during the surgery or after. So a lot of our patients will come in and be like, yeah, it is kind of weird. After I had my tonsils out, I had to go back into the ER because I couldn't stop the bleeding. Or, yeah, when I had my surgery, my provider said, man, you did bleed quite a bit. Those types of things can start to make us look into it as well. And then really more on the starting to get into more severe bleeding concerns. Some people that have bleeding disorders can have bleeding in their GI tract. So whether that shows up as blood in their stool, or you can have blood in your urine, depending on certain things. With some of our more severe bleeding disorders, you can also have spontaneous bleeds into the joint or the muscle, which again is not a super common feature, but it is something with bleeding disorders that we're often watching for, because if you have bleeding into your joint capsules or into your muscles, but especially your joints, over time that starts to create a lot of scar tissue and arthritis, and it can start to even impact like what's the mobility of the joint and chronic pain. And so we're often having discussions. Our physical therapists are huge parts of our teams when it comes to bleeding disorders, because they're working with patients to say, how do you identify when you have a joint bleed or a muscle bleed? Because to most people, that's nothing they've ever experienced before and don't know what to feel for necessarily. But we're also trying to say, hey, if you think you had one of those bleeds, let's treat as quick as possible, just so that those long-term effects to your joints are as minimal as possible as well. And then
I was going to say with the joint, I'm sorry to interrupt, but I was curious about the joints. Like, so how do people even notice that they have that bleeding into their joints?
It's a lot of work with the doctors and the physical therapists to kind of learn your body, but a lot of times it is looking for things like heat and swelling and redness, and trying to figure out, does this feel like a bleed versus could I have tweaked my joint in a different way? But there's just different mechanisms. Now, if we're questioning if there's a bleed, there's special like imaging and ultrasounds that our PTs can do on your joints to see, is there an active bleed? Is there evidence of an old bleed? And just kind of help you out there. But it's a tricky business, and it's one of those that our physical therapists are constantly working with our patients to really try to feel, what does their body feel like in a bleed, and making sure that we have all the medications on hand if that were to happen as well. And then I guess the last kind of bleeding symptom that comes to mind, and again is in more severe cases, is that you can have, something like a brain bleed, whether it's spontaneous or whether it's through an injury or some type of trauma. But those are all, again, the spectrum is so wide, and even in the same family, the spectrum can be wide. And so it's one of those that when we're looking through and trying to figure out if somebody may have a bleeding disorder, it's very nice because the ISTH, which is the International Society of Thrombosis and Hemostasis, came out with what they call a BAT score. It's BAT, standing for Bleeding Assessment Tool. And it allows providers, genetic counselors, it's out of my scope to give somebody a BAT score. But I think it's a nice way for physicians or non-hematologists to kind of start to know, what should I ask about bleeding? And it has each category. So you go through and you say, hey, do you have nosebleeds? If yes, then this, or this, and you get certain points on how severe they are. How about your periods? And you get extra points, and then you add it up. And at the end, there's different categories for men and women to say, ooh, you have a high bleeding score that's indicative of a bleeding disorder, or you fall under that score, maybe we look at some other options. So again, the BAT, those BAT scores are maybe not something that every provider can really assign to a patient, but I think it has really nice questions for both patients and providers to ask to try to see if it feels like there could be a bleeding disorder underlying somebody as well.
Okay, that's very helpful, because I think that's one of the questions I have too, is that with kind of the spectrum being so wide of different presenting symptoms, like you said too, it can look different even in the same family. I'm wondering, like, what kind of doctor, what kind of healthcare professional picks up these folks or says, hey, we may need to take a deeper look at this.
I think that it can come from several different directions, and sometimes it's also patient driven as well. But I think we're trying to really help providers in certain settings to notice if something seems atypical. So, for example, we're really trying to share awareness with dentists that if you're doing dental work and there's quite a bit of bleeding, or there was bleeding with tooth extractions that just doesn't quite seem right, let's maybe ask about personal and family history of other bleeding concerns. Because if you have gum bleeding plus heavy periods, we should probably see you. I think that gynecologists have become well aware of some potential ways to distinguish if your period is too heavy or not, but they definitely are a really strong tool that helps us say, these periods are too heavy, and we don't really have another reason to explain them, like fibroids or PCOS or things like that. So maybe we should look you up for, or have you evaluated for a bleeding disorder. And then, sometimes you're going into an ENT because of nosebleeds and cauterization. And if the ENT's like, man, this is your second cauterization this year, and your dad also has gnarly nosebleeds, maybe we should have you evaluated for a bleeding disorder. Surgeons may also recognize, hey, there was extra bleeding during that procedure. Let's make sure that we look at this. So there's different avenues, and maybe your PCP is also one to help you look into it, which I hope that our PCPs just continue to be more aware of some of these things, because that's who you're often seeing the most. But ultimately, it tends to lead to a referral to a hematologist. Now, I work as part of something called a hemophilia and thrombosis center. It's pretty much a bleeding and clotting center. And there we call it for short an HTC. And there's many HTCs across the United States that we not only have hematologists, but we have hematologists that are very specialized in treating individuals that have different types of bleeding and clotting disorders. And so there's sometimes families that only have access to maybe a traditional hematologist who sees a bunch of indications, and that's great. That is a perfect home. There's also sometimes where it might be beneficial to have a referral to an HTC just because it's their bread and butter, and we have a little bit more tools in our tool belt to be able to work people up, or maybe some different resources for families with different bleeding disorders. But you can come to us from a variety of different directions, but ultimately, if you can be established with a hemophilia and thrombosis center and HTC, it's just kind of almost the center of excellence to that particular indication.
Okay, that's helpful to know. Yeah, I was kind of trying to figure out, like, what is the expert area, that you're trying to potentially get to, or that the type of clinic that may be helpful. One area I wanted to dive a little bit deeper on is thinking about bleeding disorders and menstrual bleeding or periods. How does a bleeding disorder affect periods?
A lot, I should say. Or if you asked a female with a bleeding disorder, that's often, like you said, going to be their main, or I shouldn't say their main, but one of their primary bleeding concerns or problems is during menstrual bleeding. And really, I mean, when you have your monthly menstrual cycle and you shed the lining of your uterus, it's again a bleeding challenge is kind of what we use in our world. Of any time that you have, again, damage to any of your blood vessels that creates bleeding, you need to have a counteraction to stop the bleeding. And with those that have bleeding disorders, you're having a period, just as you should, and then the bleeding that continues is just heavier than it should be. So in our world, again, there's a lot of different reasons that somebody can have heavy periods. And so we always really encourage somebody to work with a gynecologist and a hematologist to try to figure out if we can put our finger on what it is. But, some people are like, when is a period abnormal? Because It's usually not table talk. It's also not something we all talk about with our neighbors. But hopefully it is something that we start to talk about, at least with each other and with our providers, because there's a lot of females out there that have heavy periods and have no clue that they're considered to be atypical. So, in our world, we usually will ask a few different questions of, are your periods lasting longer than 7 days? Because that's typically they should be about 5 to 7 days. Are you going through any of your products like a pad or a tampon within 1 to 2 hours? Are you having to double up and wear a pad and a tampon at the same time? Those types of things. If you're passing blood clots during your periods that are usually say about a quarter size or larger, not typical. Those are all things that we start to look into if that's happening and we can't find kind of an anatomical or other reason it's happening, we'll start to work you up for a bleeding disorder. So if anyone has those, I think it's always good to start to talk about it with your providers and have no shame about it, because I think we all need to talk about periods more. It's something that happens once a month for the majority of us, or at least half of us. So I think it's a topic that's becoming more and more spoken about as well.
Mm-hmm. And I appreciate those examples too of what counts potentially as too heavy, or at least, hey, ask some additional questions, because I think you're right. A lot of folks, are not told that there could be a range, right? And that even though there's a range, there's still some that make us more concerned for other things. So when you're seeing these signs, this is when to talk to your provider and see what, get some more information, see what they think.
Exactly. And I think it's a sensitive topic in terms of sometimes younger females don't really want to talk about their periods, and they're definitely not going to talk about bleeding through their clothes or having to bring extra clothes places because they're bleeding through it, or sleeping on a towel, or having to set an alarm to change your pad or tampon. Again, things that we're just trying to bring awareness to, because there are tools that we can use to make that more manageable and less traumatic too.
What are some of the things that you think about with pregnancy and childbirth and bleeding disorders? So you'd mentioned earlier about maybe prolonged bleeding after childbirth, but are there other considerations, in that stage of life if somebody has a bleeding disorder?
We always ask all of our patients who are female patients, if you do become pregnant, please just let our clinic know. And it's kind of for a couple of different reasons. The primary reason is that we want to do some planning for your delivery so that we can either prevent extra bleeding or have things on hand if you do have extra bleeding. And so interestingly enough, there's not typically a lot of bleeding that happens during the pregnancy itself if it's a typical pregnancy. If you do happen to miscarry, then you may have some extra bleeding compared to somebody without a bleeding disorder. Or if you have a procedure like a DNC, again, any type of procedure is going to put you at a bleeding risk. And so we like to know while you're pregnant, just in case any of those things were to happen, or you need to have an emergency delivery of some sort. But the ultimate goal is that we're planning for the delivery itself. I mean, delivery, especially a vaginal delivery, tends to cause blood loss, but it shouldn't cause too much blood loss. And again, we're just coming up with a plan of when are you going to deliver, give or take? Where are you going to deliver? Let's make sure that all of your teams are aware that you're at a bleeding risk and what medications we need to have on hand. If you do have, a extra bleeding during the delivery, or you hemorrhage after the delivery, we kind of are aware and ready for that. And then, especially in the world of hereditary bleeding disorders, we're also like, do we need to be thinking about testing baby either at birth or kind of within the first year of life to see if they're at that same bleeding risk? Especially if you're having, a male in terms of a child, there are procedures that happen really early in life, like circumcisions and things like that. And so understanding if your baby may be at risk of a bleeding disorder early on might be something that we're looking into as well. So during the pregnancy, may not need a ton of intervention from your hematology clinic. In fact, some of your clotting factors actually increase during pregnancy. So there's almost a little bit of protection there. And it's also a good note for those that are trying to test for bleeding disorders during pregnancy that certain of those bleeding levels may actually, or the clotting levels may come up a little bit during pregnancy and may not give you your baseline. So it's really important to talk to your doctor if you're trying to test for a bleeding disorder while you're pregnant to understand, am I getting my accurate baseline now, or could they be artificially different and I need to test again after I'm not pregnant as well?
Okay, that's very helpful to know. One question I had too is, with bleeding disorders, is it something that can be cured, or, are medicines? So what happens when somebody comes to your clinic, they are diagnosed diagnosed with a bleeding condition, what changes then, or how is it managed?
It's in a bunch of different ways is probably the easiest answer, but it really depends on what bleeding disorder you have. I mean, there's, bleeding disorders that are severe enough that we're doing preventative treatment. And in our world, we call that prophylactic treatment, or you'll hear people saying, I'm doing prophy treatment. In some bleeding disorders, if you're at enough of a bleeding risk that we know that spontaneous bleeds can happen and we won't really know what triggers them, we just put you on a regimen that you are treated all the time to prevent those bleeds from happening. We have people that are on preventative treatments all the time, whether that's through, a lot of times with some of our traditional like hemophilia A and hemophilia B, those are treatments that you are infusing directly into a vein. And so you do over time often learn how to self-infuse if you don't have somebody with you. So there's on kind of the more severe end, there's maybe not daily, but very routine treatments that happen to prevent bleeds, all the way down to treating just kind of as needed. There's some bleeding disorders where like, we don't need to treat you all the time, but if you have an injury or you're expected to have a procedure or you're having a kiddo, then we need to maybe have things on hand to treat if there's extra bleeding. So the timing and frequency of treatment is very different depending on not only your bleeding disorder, but what we're kind of the severity of it. When it comes to the different types of treatments, in general, one of the things that we're often doing is whatever you're missing or whatever happens to be defective in the clotting cascade, we might be picking a medication that either replaces that so that your domino to a blood clot works effectively, or we might be just going around that domino with medications that say, hey, you don't have enough factor VIII in your blood. And so we have a medication that just goes around that domino and helps you form a blood clot. So there's different ways that we can give you. A lot of times these days, we're giving you synthetic forms of these different clotting factors, or we're giving you medications that kind of mimic them in the blood. In some cases, with people that have platelet disorders, we may be giving them platelet transfusions, which is platelets from a donor other than themselves to replenish their own. So from a kind of treatment standpoint, those are what we're looking at. Now, in the last few years, that's kind of maybe more from a management standpoint. But in the last few years, we've actually had gene therapy come about, especially in the world of hemophilia A and hemophilia B, where we are giving the body pretty much a fresh source of DNA to do what it needs to do that what it wasn't able to do before. So in this case, for hemophilia A and hemophilia B, it's giving your body the instructions it makes or needs to make for those clotting factors to be made in the body and help you form blood clots as expected. With those are kind of traditionally thought of as a cure because it's a one-time treatment and it will give your body the ability to make what it needs to on its own, and you aren't having to do treatments after that. Interestingly enough, there was FDA approval of gene therapy for hemophilia A and hemophilia B a few years ago, and the adoption of those treatments has been very slow. I think in general, gene therapies for hemophilia A and hemophilia B just haven't been as quickly adopted as maybe we expected for a few different reasons. One being cost and insurance coverage. These are typically $2 to $3 million in terms of a gene therapy infusion. And there's just been a lot of logistics of trying to figure out coverage for that. And I think even more than cost has also been that a lot of individuals that have a bleeding disorder, especially hemophilia A and hemophilia B, have a treatment plan that is working well for them. And so it's one of those questions of, we have a lot of patients that are like, I don't know if I want to be an early adopter of a brand new therapy when what I have is working well. And I also think that there definitely needs to be mention in the world of bleeding disorders of kind of the history in terms of treatment with bleeding disorders, especially with hemophilia. So back in, prior to like the 1970s or so, when somebody had hemophilia A or B or bleeding disorders, the most common way that we treated them was giving them products from other people's blood that they knew we knew they were missing in their own. And with that, in the late 1970s, early 1980s, we found out that there were a lot of bloodborne pathogens like HIV and hepatitis that were incidentally given to this population as part of their routine treatment. And so there was a very large number of patients with hemophilia A and hemophilia B that contracted HIV and or hepatitis during that time. And given we also didn't really know the mechanism to how it was contracted. There was a lot of them that ended up giving it to their partners as well. And it was devastating to the community. And there was a lot of not only distrust that came through the medical community after that from that population, but there was a lot of stigmatization in terms of those with hemophilia were thought to also be connected to those that were either homosexual or intravenous drug users, because those were the populations most likely to have some of those conditions at that time. So all that to be said, since then we have come up with a lot more reliable of treatments that include using synthetic products versus products from other humans. And there's also a lot of safety involved in terms of screening our blood products. But with all of that, I think that this particular population is a little hesitant, and understandably, to adopt brand new therapies, just given the history of things as well.
No, and I appreciate you giving us the kind of historical context of really how far things have come in terms of treatment, but also the lasting effects of what has happened over 40, 50 years ago. And again, trying to increase awareness and rebuild that trust with certain communities. You mentioned hemophilia. What are some other examples of bleeding disorders? Because I know it's different factors, but I'm wondering if there's some that folks may have heard of before.
I think when it comes to being household terms, some of these may not be all that well known, but once you get into the bleeding disorder community, you start to realize they're actually more common than you'd suspect. And the most common hereditary bleeding disorder of all of them is actually von Willebrand disease. And then, other ones that you may or may not have heard of: hemophilia A, hemophilia B. Technically, hemophilia C is factor 11 deficiency. All of the different factors like factor 5, factor 7, factor 11, factor 13, all of those can, if you don't have enough of them, be a bleeding disorder or a factor deficiency. So there's kind of that side of things. Along the same lines, there's some families that we follow that have things like a fibrinogen disorder. Again, just one of the dominoes that is involved in a blood clot that might be missing or not working correctly. And then there's a whole world of different platelet disorders as well. There's families that have low platelets, or there's families that have platelet defects, or there's families that we know some parts of their platelets, like their storage pool granules, are not as expected. So the platelet disorder community is also a large part of our bleeding community. And I think we're constantly learning more about those, just because they're kind of a hot topic lately as well. Other things that are other conditions that we might have heard of: hereditary hemorrhagic telangiectasia, HHT, is another one that the most common bleeding feature that you see with it tends to be nosebleeds, but some of the women can have heavier periods, bleeding with childbirth. And then, a large or growing number of our population has a bleeding disorder, but we just can't quite put our finger on it. They match CAT or criteria in order to be diagnosed with a bleeding disorder, but we have not found the specific cause. And in our world, it's often referred to as BDUC, which is BDUC, or bleeding disorder of uncertain cause. And we want to make sure that individuals that have that bleeding disorder feel very welcomed in this community too, because they have all the same signs and symptoms as some of those that have a diagnosed bleeding disorder. It's just taking us a little bit longer to put our finger on what's going on with those particular families. And I think not only will advanced lab assays help us understand that more, but I really think genetics is going to play a big role in helping some of those families learn about a specific diagnosis. But those are kind of the more common bleeding disorders that we see. Of course, there's very rare ones as well, but those would probably be the more common ones you'll come across if you're reading about bleeding disorders.
How do you diagnose somebody with a specific bleeding disorder? Because like you mentioned, there's I don't know, hundreds, thousands probably, plus some that are unspecified or we don't necessarily quite know the cause of. So if somebody comes into the clinic, how are they evaluated and worked up?
There's quite a few different things that tend to happen. And to be perfectly honest, as a genetic counselor, I am not on the front end of a lot of that. A lot of that's going to be done through a hematologist or maybe even a PCP. But, some of the there's a lot of times there's tiered testing to this. So they're going to test you maybe for a few different screening pieces and then use an algorithm to figure out, okay, what more specific should we look into? So, we'll often start off with a screen like a PT or PTT and try to see, is your bleeding time typically normal. And based on what may be abnormal, they'll start to go down certain types of different paths to test different levels in the blood. So if we suspect you may have hemophilia A, they're testing things like factor VIII. If we suspect you may have von Willebrand, we're testing things like your von Willebrand factor. And there's quite a few different levels that will often be sent at the same time, just because it's hard to really look at somebody and their bleeding symptoms and say, hey, your bleeding symptoms seem like hemophilia A. That's really not typically how it works, because there's so much overlap that you're going to have quite a few blood levels tested to try to help us figure out what may be causing it. And, a lot of times what happens is either you'll be diagnosed with a bleeding disorder by saying, hey, you have lower von Willebrand levels in your blood than suspected. You meet criteria for von Willebrand disease. We're now going to follow you for that. Sometimes that happens, and then you see a genetic counselor and we talk through maybe the pros and cons of genetic testing. Sometimes we're part of the diagnosis journey with you, where it's, gosh, we can't seem to put our finger on what's causing you and your family's bleeding. Let's send more of a broad panel and see if we can put our finger on it. So there's a few different ways that we can work somebody up for a bleeding disorder, but a lot of times it's going to involve quite a bit of blood work at the beginning, and then genetics can sometimes be a supplement that helps us either confirm or search for an answer as well.
Yeah, so genetics isn't always the first step. It does sound like it's still very important to do initial testing in terms of seeing like how much of certain factors are present or what might be absent.
Exactly. And, there's different ways that we can, for those that maybe don't give us our answers in the first round of testing, maybe we look closer at your platelets, and we not only look at your platelet counts, but we look at how do your platelets stick together through something like a platelet aggregation study. There's a bunch of different ways we can do it, which is why I also always just encourage those that if you seem to meet criteria based on your bleeding features for a bleeding disorder, that seeing a clinic that's very familiar with sending all of these different testing can be really helpful, just because a PCP may not send some of these tests all that often. And it is important to know timing of testing. Again, are you pregnant? Was there recent, stress or inflammation in the body? Because that can artificially increase some levels. Little kiddos, when they're super stressed out around a blood draw, some of those inflammatory clotting factors like von Willebrand can increase, and we don't know if we're getting their baseline or if we got their stressed baseline. So just being with a clinic that really feels comfortable of how and when to send these and how to interpret the results when they come back is really important too.
One thing that I was curious about, and I think it was mentioned some in the talk, was how long people can go being undiagnosed, so that it can often take a while for somebody to come in to the attention that they may have a bleeding condition. Are there certain symptoms that tend to be more overlooked or dismissed?
I was recently presenting on von Willebrand disease at a conference, and I came across an article that had explored many women in this particular study that had von Willebrand disease. And they said that the average woman had a 16-year gap between the onset of her bleeding disorder symptoms and her diagnosis. And we've been very good, I think, in the past of being able to diagnose and identify, especially the males with hemophilia A and hemophilia B, and some of the more severe bleeding disorders, because they are more apparent earlier in life in terms of the bleeding can be more severe. But I think especially a hot topic in our world recently has been trying to promote finding these women with bleeding disorders earlier and making sure they have the resources that they need. And historically as well, we have a lot of women with things like von Willebrand disease that just have had those heavy periods, or maybe they hemorrhaged with the delivery, but the doc was like, oh, well, it was kind of a complicated delivery, so I wouldn't worry about it. There's just a lot of normalization that happens in terms of some of those things, not only by the medical community, but also within a family. A lot of times it's like, well, I thought that having 10-day periods and bleeding through my clothes was normal because my mom and grandma had the same experience, so I didn't think to question it. And we're just really trying to get the awareness out there earlier to help with that. But, in general, we are trying to have the diagnosis be earlier, and we're really trying to make sure the awareness gets out in terms of what is abnormal bleeding so people can seek that out. But I would definitely say that a lot of the delay comes from some of these bleeding symptoms being more subtle than we would expect. And maybe they're not life-threatening bleeding, but they're certainly not comfortable, and they certainly can make you feel not great and run down your iron levels, and you might be running anemic and things like that, that just start to compound when we're not addressing the underlying bleeding disorder as well.
And you mentioned some things that I think that patients or folks can look out for, but what are some things that maybe you would wish healthcare providers either understood or were able to recognize in terms of bleeding disorders?
I think that a lot of times primary care providers they're handling so much of your care in a very short appointment. So I understand that addressing some of these things on a normal basis is time consuming and maybe not realistic in that setting. But I do think that even some simple questionnaires or even just questions to females of what is your average time in terms of a length of a period, and how often are you going through a pad or a tampon? Two simple questions could probably identify a lot of our women with bleeding disorders years before we catch them otherwise. And so, and again, trying to raise awareness of other specialties like dentists and surgeons and gynecologists of when is this bleeding not normal and when should we work it up more versus maybe this was more situational. So I think that our education in that realm is getting better, but I think that it'll also take some patient advocacy as well of going in and being like, hey, I've really been reading and my periods don't seem normal. What do you think? And bringing it up because it may not be something that your PCP thinks to bring up at every appointment or even just after you've started your period as well. Same goes with a gynecologist.
For the families and patients that you've worked with that do have a bleeding disorder, what are some of the things that they face? What are some maybe like just emotional, even logistical, psychological types of challenges? What kind of comes up once they are maybe officially diagnosed?
I think it can really range depending on the severity of your bleeding disorder because there are bleeding disorders that may impact recommendations we do or do not have for maybe some activities that you participate in. So for some of our families that have severe bleeding disorders, we may say, hey, high contact sports like football and things where you're constantly getting bonked around may not be the safest choice for you. I know that our hemophilia center, and I know almost all hemophilia centers, the HTC bleeding centers, we really do try to support everyone's goals and dreams and try to meet you there with safety. But there are some times where we have to say, hey, this risk outweighs the benefit, and what would you like to decide here? So I think that there's a lot of from parents that find out that their kiddos have a bleeding disorder from a young age, there's this question of how is this going to change their life? How is it going to impact their decisions? And I think our center and a lot of centers really try to say, hey, we want them to live their life, and the bleeding disorder is going to be something we support from the background while keeping them safe. But there's going to be some times where there's maybe some sacrifices in terms of activities and things like that we're doing. All that to be said, though, there's some really incredible stories. There's a documentary that's out on, I think it's on Prime Video, where Chris Bombardier, he is actually a patient at our center in Colorado. But he did a documentary. He has severe hemophilia, and he did a documentary while he was climbing the seven highest peaks throughout the world and documented that journey. And it's a really neat one to just see, he talks about growing up with hemophilia and he talks about the challenges that he's had. He also visits individuals in local clinics and areas that have hemophilia who have had a very different outcome based on the medical care that was available. But that's just a really good example of our providers worked with him to say, hey, you would like to do this goal of climbing all of these mountains. You have to bring all your meds with you. You're going to have to self-infuse, but we're here and let's see how we can do it. So from a psychological aspect, I think there's always that question of how is this going to impact things that I can do in life? But I really think that we try to balance trying to make sure you do what you like while keeping you safe. I think that there's other things that can end up, being very challenging in terms of, I know we've talked about it quite a bit, but, with heavy periods, the logistics of having heavy periods can impact, if not daily, monthly life. You might be having to leave and ask to leave class or school to go change products. You may be missing school or work for that. It's also embarrassing to bleed through your clothes and have to carry extra clothes. So those different pieces can not only impact females with bleeding disorders, but I do hear it more from that area as well. And then we talked about it a little bit earlier too, but there in a lot of our bleeding disorder families that maybe have more severe levels, they can really deal with chronic pain as part of their condition and trying to figure out how to cope with chronic pain, treat chronic pain, not treat chronic pain with other substances that might temporarily make it feel better. There's a lot of balance that goes on, and chronic pain is a very hot topic in that world of trying to make sure that we get support for families and both mental health and physical support for chronic pain, because that can be really, really debilitating in some cases as well. Other logistical things, I mean, cost is always something that families are thinking about. We talked about the cost of gene therapy, which probably hasn't impacted too many families, but there's also the cost of just general medications for bleeding disorders can be very pricey. I think they say the average treatment for someone with severe hemophilia A or hemophilia B is like $300,000 to $500,000 a year for treatment. And you're having to really work with your insurance companies and grant funding and things to try to make ends meet. And I think that that can be a huge challenge for a lot of our families as well. And I think the last thing, and we've talked about this too, is just there's a lot of psychological burden where families are like, I've come and I've had doctors tell me for decades now that my bleeding was normal. It's really nice to hear that it wasn't, but it still makes me feel like, am I an imposter for saying I have a bleeding disorder and trying to kind of convince them that this is real, you deserve care, and we want to make sure you've got well-rounded care as well.
What are some of like the resources or maybe support that you recommend for some of the patients and families you've seen?
You know, there's a lot of great organizations. I think the most well-known is going to be the National Bleeding Disorder Foundation, or NBDF. They support many different types of bleeding disorders. They have a really wonderful bleeding disorder conference every year that not only has the healthcare providers, but it's even mostly focused on patients and families. They are lived experts. And we welcome having that collaboration at that conference. So I would say that's a really nice resource. And that NBDF has local chapters as well. So we have Colorado chapter here, and there's mostly state chapters, if not like a regional chapter. There's also the Foundation for Women and Girls with Blood Disorders, the World Hemophilia Foundation. There's a Platelet Disorder Support Association for those with platelet disorders. It's not necessarily a resource, but I think a really good watch for those that might be interested. There's a documentary that's called Dismissed. I think it lives at dismissedfilm.com, and it talks about 4 women with bleeding disorders who kind of were dismissed throughout a lot of their life. They thought providers did not think back then that hemophilia carriers could have bleeding concerns themselves. And in fact, we've learned that women can have hemophilia. So that goes through that as well. So those are some really good resources, not only kind of logistically, but also just connecting with others with bleeding disorders that I think would be good.
Perfect. We'll add all of those as well to the show notes so that folks that are listening can find them. As we're wrapping up, I mean, we've covered quite a bit and also not that much. I feel like it's kind of between the two. But for the folks listening today, if there's one thing that they take away from this conversation or that you want them to remember, what would that be?
You know, I really think that if you listened to today's episode and feel like you or somebody you know may have abnormal bleeding, that it's okay to take that to your doctor and talk through those things. And I hope you go with nothing but pride and encouragement and no shame around that. And knowing that if there is question of a bleeding disorder, just maybe, asking your provider if you can see a specialized clinic that maybe can be the experts in this particular area and go from there.
Well, thank you, Kaylee, for that word of encouragement and support, I think, because I think this is one of those areas too where, like you said, people may be questioning if there is even something going on. So I just appreciate you giving us the information, giving us the additional resources, and for just sharing your expertise today.
Well, thank you so much for having me. And I really appreciate all your podcast series. I think it's great information to get out there.
For more information about this episode, visit allaccessdna.podbean.com, where you can also stream all the episodes of the show. Any inquiries on the podcast can be sent to allaccessdna@gmail.com. Please rate and review the podcast on Apple, Spotify, YouTube, or wherever you listen. This helps other people like you discover the show. Note that this podcast is for entertainment and education and is not intended to be a substitute for professional medical advice. Please consult your physician with any questions you may have regarding your health. All Access DNA is an independent podcast hosted and produced by me, Kate Wilson. Designs by NKJ created the logo. Thanks for listening and join us next time.